Let's continue with the next presentation. In order to do so, I would like to introduce you to Rosa Hoekstra. She is a lecturer at King's College of London, and she will talk about the research gap globally regarding different geographic regions. So thank you, and a warm...
Thanks very much, Andres, and thanks very much for the invitation to come and speak to you all here today. It's lovely to see such a big audience. Feel free to take my seat there if you want to sit comfortably. This is Debre Libanos. It's a mountain range a couple of hours outside of Addis Ababa, the capital of Ethiopia. It's a beautiful place, and I've included the picture here to illustrate the gap in autism research. So the vast majority of research on autism is done in high-income countries, particularly in North America, in Europe, then some work in Australia, some work in Japan and in Korea. But very little work is done in low and middle income contexts. And that's where the majority of the population lives, and it's the majority where most kids with developmental disorders live. So there's estimates of global burden of disease studies that suggest that 95% of kids with developmental disabilities live in low and middle income countries. And when it comes to autism, we do very little research in those contexts, so that creates a gap. So the first time when this gap in research was highlighted was when it came to mental health research, so not specific to autism. Shekhar Saxena, who used to be the head of the Department of Mental Health at the World Health Organization, published a study in 2006 where they had counted all studies relevant to mental health research and found that only 6% of those studies were conducted in low and middle income settings. So the vast majority is done in high income settings. So that's now 13 years ago. And then 4 years later, Henrich and colleagues published a really influential paper that focused specifically on psychological science and behavioral science, and showed that the vast majority of those studies are done in samples from Western, educated, industrialized, rich and democratic societies. In other words, weird societies, weird people, because this is not reflective of the population in the world as a whole. And it is likely that this biases our research, and that we have developed theories that we think are culturally universal, but that actually might be specific to these weird samples. This is likely to also apply to autism. Well, we know that most of the research in autism is done in high-income countries. And a couple of years ago, I was glad to work with a team of international academics, and we published this commentary where we highlighted the problem of this research divide, pointing out two problems in particular. So the knowledge of what we know about autism, what autism is, what it looks like, what causes autism, it's incomplete and quite possibly biased. And the other problem is that research is linked to capacity building. So if we, for example, primarily do autism intervention studies in high-income countries, then we develop an intervention that suits that high-income context that might not be suitable for poor countries. So ultimately, this increases in inequity in care and services. So in this talk, I am going to consider the possible cultural and contextual influences on autism that might affect identification and diagnosis of autism. So really the very first step, how do we find the children, and kind of reflective on Mayada's talk earlier, the earlier we identify children and diagnose them, if we find them early, then hopefully their trajectory later on is more positive. So how do we identify and diagnose them, and are there any cultural and contextual influences that might affect this? And I'll also give some pointers in how I think that we could do some work to improve the global representation of autism research. A lot of my thinking has been influenced by the fact that I started working with colleagues at Addis Ababa University in Ethiopia since 2010. Before then, all my work was done in the UK and in the Netherlands, so in high-income contexts. And then in 2010, I started working with colleagues in Ethiopia, and I became much more acutely aware of this gap in autism research and the consequences that it had, of how little we understood of autism and other developmental disorders in a context like Ethiopia. So I'm going to refer to some of our work in Ethiopia in this talk. So first a bit of background of the context. So Ethiopia is a country of over 100 million people in the Horn of Africa. It's the second most popular country on the African continent. Only Nigeria is bigger. And the UNDP ranks Ethiopia towards the bottom of its Human Development Index. About 27% of people in Ethiopia live in extreme poverty, so they have less than $1.9 a day to live off. About 6% of children die before the age of 5. A quarter of children are underweight, and nearly 40% of children are stunted. So these are really serious figures, but if you look at them in a more 20-year pattern, then the overall trend is more positive. So in the year 2000, nearly 17% of children still died before the age of 5, and it is now about 6%. So it's moving in the right direction, but from a very serious and problematic baseline, of course. And these serious figures are also reflected in the health system in Ethiopia, and particularly when it comes to mental health and services for people with developmental disabilities. There are 2 child mental health clinics in the country, and both of them are in the capital, Addis Ababa. There are 60 psychiatrists who work throughout the country, but only one of them is specialized in child psychiatry. And remember, it's a country of 100 million people, of which about 50% of the population is children. So 50 million are children. Children are seen by psychiatrists, but they'll be seen by general psychiatrists, so not by a specific child psychiatrist. But the vast majority of the population live in rural, dispersed communities, often very far away from Addis Ababa. So these families never make it to the clinic in Addis Ababa to get the specialist diagnosis. If they do come to the clinic, often the story is that they have sold a cow so they can make this trip to Addis Ababa once. They cannot come back for follow-up visits. And in those rural communities, services are provided by very basically educated community health workers, so there's no specialized care in those communities. And this means that autism goes largely undetected in the country. If it is diagnosed, it is the really severe cases that have co-occurring intellectual disability. I have not yet seen a child in Ethiopia that has autism with average or above average intellectual functioning. They might exist, but they don't come to the clinical attention. So that's the context. And after working there for a couple of years, I thought, well, it would really be good to think a bit more deeply about what possible cultural and contextual factors could play a role when we're studying autism. But what exactly do we mean with culture? Well, we can call it the customs, civilization, and achievements of a particular time or people, or the totality of habits, ideas, beliefs, attitudes, symbols, and values, as well as the behaviors that spring from them. Culture, we also need to sort of think, what is culture not? So culture is not necessarily related to geography. Because of migration, you can have different cultures in the same geographical place. And urban residents may have much more in common with other urbanized on the other side of the world than they have with their rural fellow countrymen. My Ethiopian psychiatrist colleagues, I'm really not very different from them, the ones who live in Addis Ababa. But they are dramatically different from the Ethiopians who live in rural Ethiopia, are often non-literate and very poor. So there are really big differences within countries too. And culture can be really neatly intertwined with contextual, especially with socioeconomic factors. So I'm not even attempting to take the two, to disentangle the two. I'm considering culture and contextual factors all in one. And it's important to recognize that culture changes over time. So what is your culture now might be considerably different from what it was 30 years ago. So taking those thoughts into mind, I had the opportunity to work with an amazing student, Anna de Leo, and we started and with Francesca Happe, who's also at King's, and we build up a conceptual framework to start to think, well, what type of contextual and cultural factors could play a role in the identification and diagnosis of autism. So we did a systematic review of the autism literature. But recognizing that global autism research is in its infancy, so we might be missing important factors if we only look at autism, we also considered a much wider body of literature. So we looked at the fields of global mental health, cross-cultural psychology, cultural psychiatry, to also consider factors that haven't yet been studied in autism, but might potentially play a role. So what we did, we tried to map possible cultural and contextual factors across the globe, with possible in italics for a reason, because we don't know that these factors necessarily play a role everywhere. So some of these factors might be completely irrelevant in some cultural contexts, but we felt it was helpful if we make this kind of comprehensive framework, then hopefully this is a springboard for future research where researchers can consider which particular things do I need to bear in mind when I'm designing my study. It's currently under review, but the pre-peer-reviewed version is available as a preprint on SciArchive. So, considering all that literature, we developed a framework that considers of 4 levels. So it starts with the expression of symptoms of autism. Are there any cultural or contextual differences in what autism looks like in the core symptoms? And then once we've considered that, how do we recognize autism symptoms? So do we recognize that these symptoms are atypical? Is this something we need to be concerned about? Once you've recognized it, how do you interpret those symptoms? Are they problematic, or do you not think they're problematic? And how you interpret them might play a role in where you seek help. Do you seek help at all? Do you seek help from a religious leader or from a traditional healer? Or do you go to a biomedical institution to meet a clinician? Once you then come to that biomedical clinic, cultural and contextual factors might play a role in how you report the symptoms. So the type of conversation that the parent has with the clinician. And I should add that in our framework, we primarily had childhood in mind, with the idea that hopefully, ultimately, this framework can help in earlier identification and earlier diagnosis. We hope it's also relevant for adults, but most of the studies that we've based the framework on are relevant to children, especially bearing in mind that caregivers and parents are often really important advocates in getting to the clinic. So I'll talk through the 4 levels in a bit more detail. So firstly, the level of the expression of autism symptoms. To what extent is the expression of autism symptoms, as we defined them in the DSM-5 and in the ICD-11, are they uniform across cultures? And one aspect that could differ is that there are qualitative differences. So the actual symptoms that we see could be different across the globe. There's very little evidence that this is the case. So the core symptoms of autism are found across the globe. And so we see them everywhere. Perhaps there is a tiny little bit of evidence that maybe there might be some subtle differences in how they are expressed. In China and some other cultures, it might be more atypical eye contact rather than lack of eye contact that you see. And one thing that I found interesting in a study that we're currently writing up, where we did a qualitative interview project with parents of kids with an autism diagnosis in Ethiopia. And we asked the parents not just what are your child's difficulties, but we also asked them what are your child's strengths. And several parents, unprompted, said, well, my child's strength is that he's really good in greeting others well. And if you look at the DSM-5 symptoms, one of the examples that is given as a social communication problem, so an example of how social communication problems can show, is that people with autism might find it difficult to greet others. So the opposite is reported by parents in Ethiopia. And we think that this is, firstly, because greeting is really important in Ethiopian society. It's very important to be polite and to greet others. And also the greeting is highly ritualized. So you greet everyone in exactly the same way. There is not this ambiguity that you have in certain cultures. Is it a handshake? Is it a kiss? How many kisses? Which cheek do I do first? That ambiguity doesn't exist in Ethiopia. You greet in one way. So kids with autism can learn it, and parents are really proud of it and mention it spontaneously. So maybe this is an example of a subtle cultural difference, but really overall there's very limited evidence. Now, are there quantitative differences? So is there any evidence across the globe that certain symptoms are more severe in particular cultures or are more frequent? Again, very little evidence. I've listed 2 papers here. I personally don't think they're particularly convincing. I think some of these findings might be because of differences in sampling rather than that these really are cultural differences. So these two papers suggest that there might be fewer rituals and preoccupations with objects in African American kids compared to white children, and preoccupation with objects was seen in a really limited way in autistic children in Nigeria. So even if the symptoms are overall the same across the globe, could it be that that culture and context plays a role in when those symptoms lead to a clinically significant impairment? To get an autism diagnosis, there needs to be an impairment in day-to-day functioning. If you have lots of autistic traits, but you have no difficulties in functioning, you would not get a clinical diagnosis. So could it be that culture and context plays a role? This is completely speculative. I haven't found any research on it, so you can speculate that maybe if you live in rural Ethiopia and you're a farmer, you wake up when the sun comes up, then you herd the cows during the day, you eat 2 meals, and you go to bed when the sun goes down. That life and the kind of the requirements of life are very different from if you were living in an urban area, you were working in an open plan office with a glaring television screen with lots of phone calls at the same time, maybe lots of different sensory sensitivities. Maybe that imposes different requirements on life that makes it perhaps more likely to tip into this is clinically significantly impairing. I'm completely speculating here. We don't know. There's no studies as far as I know. So that's level 1. Now, if we accept that overall, generally, the expression of autism is roughly similar across the world, are there any differences from culture and socioeconomic factors that may affect whether and when atypical symptoms are recognized by caregivers or by clinicians? Now, cultural norms may play a role here. If there are differences in cultural norms, then maybe particular behaviors are much more salient than others. So, for example, eye contact with authorities and elderly is shameful and disrespectful in many Asian cultures and in many African and Latino cultures. So abnormalities in eye contact might be slightly more difficult to recognize than it is in a Western context where kids are expected to make eye contact. There is also cultural differences in the frequency of children playing imaginative play and the amount of imagination that they show during that play. So maybe in countries where that play is not really that common anyway, parents or teachers won't really notice that the kid doesn't show any imaginative play. There can also be differences in there can be differences in the boundaries of what we accept as acceptable cultural norms. So there might be particular cultural norms, but when do we decide that this behavior is atypical, that it deviates from the norm? Maybe you have very narrow norms, or maybe those norms are broader. Would it be possible to get the slides back up? And so there is some evidence that there is more variability in where those boundaries lie. So, for example, in a sample of Jamaican parents and Thai parents, they accepted a wider boundary of behaviors than American parents. And in a sample comparing migrants in the Netherlands with native Dutch moms, the migrants were less concerned about child behaviors than their migrant counterparts. So this is not specific to autism, a wider literature, suggesting that there might be some cultural differences in what you see as acceptable or atypical behaviors. There's one study that kind of hints at this from the autism literature, from Tamara Daly, who studied autism in India. And she cites a psychiatrist who says there may be a tendency by our rural mass to accept and tolerate some degree of abnormality as normal. So maybe in rural India, parents are less concerned about slight deviations of the typical norm than they would be in other contexts. Recognition of autism symptoms is also strongly linked to awareness of the caregiver noticing that something in the child that is not quite as according to typical development. Now, there are different cultural norms in parenting. So there are very different parenting styles across the world. And if you are a parent of a single child and you are the kind of helicopter parent who very closely monitors every single step of development of the child, you might be quicker to spot a slight deviation from the norm than if you are a parent of 8 or 10 children and the parenting responsibility is divided among many different members of the society. The aunties, the grandparents, siblings might take a caring role. So there might be less awareness to the trajectory of this specific child. There might also be competing priorities. If you live in war or you are concerned about putting food on the table tonight, you might be less quick to spot particular deviations in child development compared to if you live a comfortable life. And then there is the issue of autism awareness more specifically. There's huge variation in autism awareness across the world, and especially in low-income contexts, awareness is really low. As illustrated by this quote from a study in Malaysia, where the parent says, "I didn't know she has autism until she got a fever. I sent her to the hospital, and then the doctor suspected that she's having autism. I said, 'What is autism?' And then he said, 'This is a lifelong thing.' Then I asked doctor how to spell, and he said, AUTISM. So even when symptoms are recognized, the interpretation of those symptoms may affect the help-seeking behavior. And this is particularly relevant to language delay. So language delay is often one of the first concerns of parents, one of the reasons why they take the child to the clinic. But language delay is not perceived universally as problematic in young children. So, for example, in India, it is well known that the Indian boy speaks late is a common belief. So if you have a boy with speech delay, you might not necessarily be concerned. And in China, a common belief is that a child that speaks late will be more intelligent than his peers in the future. So you might actually be quite pleased that your child is late because you believe that this will lead to a good outcome later on. So these beliefs, the interpretation of these symptoms might affect whether the parent seeks help and when the parent seeks help. And a wider kind of consideration of how parents interpret findings is when we look at explanatory models. So explanatory models is a term that reflects the perspectives of persons related to the nature, causes, cause and treatment of conditions. So what is wrong with my child? Why is it my child or why is it me? Why does this happen now? How long will it last? How serious is the condition? How do we treat it? These are all questions that are related to explanatory models. And caregivers' explanatory models may affect how they report symptoms, but also if they seek help and when, and what type of help they seek. And we studied explanatory models of caregivers of kids with developmental disorders in Ethiopia. This was a sample of kids with developmental disorders, so not autism only. 2/3 of the sample only had intellectual disability. The kids who had autism also had intellectual disability because, again, we don't see kids without intellectual disability in the clinic. And I should add, these are already help-seeking parents, so this is a biased sample. They've already made their way to the clinic. So we asked them questions about their beliefs about their child's condition, and we did that in a face-to-face interview because of low literacy rates in Ethiopia. What works well is if you work with a trained data collector who asks the questions to the parent. And so we asked them, what do you think has caused your child's condition? And the parent could mention as many causes as they felt were relevant. And they cited a range of both biological but also supernatural causes. So 40% of the parents thought that spirit possession played a role in their child's developmental disorder. Many thought it was due to a sinful act or due to a punishment of God. But many also cited more biomedical reasons, so a head injury or complications during birth. And over 1/3 of caregivers gave a combination of both types of reasons. So they may said, I think my child's condition is due to spirit possession, but it might also be because I had complications when I was giving birth. So these types of explanations are not mutually exclusive. And this has been found in many other countries and cultures. So this is not specific to autism. You can very well have different causal beliefs that can coexist at the same time. But these beliefs might affect where you seek help. So the vast majority of the parents in Ethiopia, when they get to the biomedical clinic, they've already been to lots of religious help or traditional healing institutions. So they first seek help from the religious leader, and only later on do they come to the biomedical clinic. And so when we ask them what type of treatments have you used, well, some have had medication because their child may have epilepsy or anxiety, for example. Many have tried religious treatments, traditional treatments like wearing a script around the neck, but also religious interventions like prayer. Physical punishment is still very common in Ethiopia, so a substantial percentage of parents said that they used that in the hope that it would improve the child's behavior. The chaining of the child, that was reported by 9% of the parents, that needs some context. So we presented these results to our Ethiopian stakeholders, that includes parents of kids with developmental disorders and service providers. And they said the chaining of the child is not a punishment. It is not done with the idea that the child will improve in their behavior. It is done as a last resort. No one else is able to take care of the child. If the parent needs to go out to the market to buy stuff, the only way to keep the child safe from harm is to tie the child up at home. So this is not seen as a treatment, it is a last resort. So interpretation of symptoms can play a role in whether you see it as problematic and whether you go and look for help. Even if you've decided that really you need help, there might be barriers before you can find that help. And big review studies on looking at health services and barriers and facilitators to help seeking suggest that there are several barriers that are found across the world. Affordability of health services is a big problem. If you need to pay to access the health services, that might not be possible. The services need to be available in the first place. As I said, in Ethiopia, there are very few specialist services. All those services might be a day's travel away, so they are not accessible. There might also be acceptability issues with health services. So there might be concerns, for example, that your child will be taken away to social services if you come with a problem. Or there is the concern that these health workers don't really know what they're doing, so it's not worthwhile to go to the health center to seek help. And a big issue is stigma. So it is an important barrier to help seeking for parents. We have studied stigma in some depth in Ethiopia, and this is from an ongoing study that we're nearly ready to publish, where we interviewed parents of kids with developmental disorders in rural Ethiopia. And here's a quote from one of the parents who lives rurally. For instance, when I take out my child, just ask me who doesn't turn around to look at him. Everyone turns around to look at him. That is just it. I just suggest to them, watch where you're going so that you don't fall. This is what I mean. There is no one who doesn't turn around to look at him. And here's another parent living in the same community. It is people, their attitude, which makes you sick when you try to take your child out. This is maybe because of lack of awareness, but their attitude is not good. Now, this context makes it difficult for parents to take the child out, and in Ethiopia it's really common for children to be locked away at home. So health workers in the community don't know that these children exist because they are hidden away at home because of the stigma and discrimination. So we have all the barriers, but then after the barriers, some people do come to the clinic. They manage to get there, and once they are there might be cultural or contextual factors that influence the quality of the information that the clinician receives, on which the clinician can base their diagnosis. The aim of the caregiver on the visit can play a role in what the caregiver reports. Is the caregiver looking for a cure? If they're looking for a cure and they realize that you as a clinician is unable to give it, they might never come back, so this might affect follow-up appointments. The perception of the clinician may play a role in what the caregiver discloses. If the status of the doctor is really high, like for example in India, where the status of the doctors is next to God, then what a caregiver reports might be very different. Non-literacy or languages can be a barrier, especially if you live in a context with lots of different languages. Ethiopia has 80 different languages, so language diversity can be an issue. And this is true in lots of other contexts too. For example, in Latino families who live in the US, where the clinician might only be English speaking and may not speak Spanish. In low awareness contexts, the reporting of parents might focus primarily on issues with the child that have a huge impact on the practical day-to-day functioning of the family. For example, of the lack of self-help skills. My child still can't feed themselves. My child is not toilet trained. Or really severe challenging behaviors like aggression or head banging against a wall. So when we interviewed our parents of kids with an autism diagnosis, so these are parents who already have a diagnosis for their child, when we asked them about their child's issues, these are the main things that they bring up. The lack of toilet training, the aggression, the self-harm, not the my child doesn't use gestures in communication. So this can be potentially a barrier in making a diagnosis. So all in all, we developed a 4-level framework that I realize you won't be able to read all the factors. Go and download the preprint if you're interested. But at all the 4 levels, we identified factors that might affect the identification and diagnosis of autism. And we're hoping that this framework can help in future studies to form a framework for you to think about which particular factors do I need to bear in mind when I'm conducting my studies, or what do I need to think about if I want to avoid inequity in service access in my community. So we're hoping that this could be of help. And we hope that this maybe can help in increasing global representation in autism research, the increase in research in low and middle income countries, but also the increasing in diversity within high income settings. If you scrutinize the methods section of a lot of autism papers, many of the participants are from urban areas and they are relatively highly educated and relatively high social class. It is generally not a representation of the population overall. And this can lead to issues. So, for example, there are screening measures that initially looked really promising, and now that they're evaluating them in poor settings or diverse settings, the screening measure doesn't work as well. So I am hoping and hopeful that we can improve in the diversity in our studies so that we can get a fuller picture of what autism is, how we can diagnose it, identify it, and what type of treatments might help. So a couple of pointers of how, based on our experience in Ethiopia, what you could do to increase this representation. Now, our main experience is you need to involve stakeholders right from the start. So don't disseminate your findings when you're done, but get them involved right from the start. So you invite experts, local service providers, parents of kids with autism. If you have them invite self-advocates, again in Ethiopia, I don't know of any autistic people who are verbal, so who can express themselves. If I have identified them, I'd love to introduce them to our stakeholder group. So involve them in your work so that you know that the work you're doing addresses a locally identified need, that people find it important, the work that you do, and that the work that you do uses culturally appropriate methods and materials. Are you recruiting in the right place? Is that where the people with autism come that are the full representation of the sample overall? Are you asking the appropriate questions? Are you using data collection that is appropriate for the local area? To give an extreme example, if I would use an online survey in Ethiopia, I would read maybe 0.5% of the population. It would be completely useless. There might be a useful method when you live in a high-income, well-connected context. It is completely impossible in a context like Ethiopia. And think critically, are you considering the full range of your participants? What about vulnerable groups and minority groups? Are they unintentionally excluded from your study because it's just too difficult for them to take part? So in Ethiopia, it is really important to also have the stakeholders on board when you're interpreting the findings. Think of the example of the chaining that I would have initially misinterpreted and that they made very clear how we should interpret it. And if you involve the community right from the start, then your work can also contribute to research capacity building and capacity building for services, because it's much more likely that your interventions that you've developed will actually be implementable. Think about where you are organizing these meetings. So what's the best way to ask for their feedback? In Ethiopia, email is useless. People don't respond to email. Even if they are online, they just don't really do written feedback. They love giving comments in an interactive workshop where there's good Ethiopian coffee with some nice snacks, and then you get lots of feedback, so it works really well. And I would say the same advice applies when you try to do this work in high-income settings. So think about where to find your participants and how to engage with them. Now, what from now on? What are the next stages? There are some promising initiatives, I think. Professor Amina Abubakar from Kenya, from Aga Khan University, is leading a group that is developing a global screening measure for autism that hopefully can be used in more diverse settings. There are initiatives to try improve identification of kids with autism across the globe. So the World Health Organization has this MH-GAP program to increase capacity of several cadres of health workers, and developmental disorders, including autism, is one of their specific packages. In Ethiopia, we developed a training module for community health workers to teach them about mental health, but also to teach them more specifically about developmental disorders. And we wrote about the impact of the program in a paper in 2017. It's one thing to identify kids, to detect them, but what if there are then no services whatsoever? So we need interventions that are suitable for low-resource settings. Now, I know the next speaker, Lauren Franz, is going to talk to you all about that, so I'll keep it brief, and we'll talk about one particular intervention that we are testing in Ethiopia, and that actually colleagues of Lauren are also testing in South Africa. So the World Health Organization has developed the caregiver skills training, and this is a program for parents of kids with developmental disorders, and it aims to teach the caregiver strategies to help them, support them in their child's development and learning. And the big idea is that the program can be delivered by non-specialists. Now, that would be the only way to ever scale this up in a setting like Ethiopia. If you need specialists, you could never, ever make this work. So we got involved with the WHO team at an early stage and gave them lots of feedback on their draft materials. And the pilot program is now in various stages of testing in 28 countries across the world. So we did an extensive consultation in Ethiopia. We showed the draft materials to all our stakeholders, and we asked their feedback. So we asked, is this relevant for Ethiopian parents? Does this address the need? Is the delivery model culturally acceptable? So we made quite a few cultural tweaks, and then piloted the program both in Addis Ababa and in rural settings. And here is a quote from one of the parents. I didn't expect that they would know what we were feeling deep down, that they would present it to us in the lessons. I didn't know that they knew what we were feeling inside. I came here just to check it out. And when I took one class, I saw a lot of the things that were in my life. All the problems that I had at home were written down in this book. So that was published earlier this year in the journal Autism. So I'm hoping that altogether this work, if we are more attuned to possible cultural contextual influences, if we think about them when we are designing our study, if we engage with the community that the study is for at an early age, then I'm hoping that that can ultimately help in closing this gap in autism research, so autism research becomes more representative of the global population as a whole. I'd like to thank my colleagues in Ethiopia and at King's College London and the funders. So thank you.